Our last presentation today is by Dr. Kareem Fakhoury. He is a radiation oncologist at LCMC, and he'll be talking about considerations for CNS management in small cell lung cancer. Thanks.
Hey, thanks so much for having me today. Appreciate the invitation to speak. I'm a radiation oncologist within the LCMC health system here in New Orleans. So I work at University Medical Center and West Jefferson Medical Center. So as we know, brain metastases are extremely common in small cell lung cancer, almost twice as common as in non-small cell lung cancer. And about 10 to 20% of patients will present with brain metastases at diagnosis, many of whom have asymptomatic disease. And the incidence of developing brain metastases increases over time, as you can see in this figure from the Slotman study, that these patients approached about a 50% rate of brain metastases at 18 months. The reason for this is the blood-brain barrier, which creates the brain as a sanctuary site. This was recognized in the 60s and early 70s as we saw that chemotherapeutic agents would provide really significant responses extracranially, but then patients would have high rates of failure in the CNS. And this led to the development of the technique of prophylactic cranial irradiation, or PCI. So these first generation trials that were done in the 70s and 80s showed that PCI was very effective in preventing the development of brain metastases. But each of these studies by itself lacks power to demonstrate a survival benefit, possibly due to the older techniques that were used in terms of radiation and higher doses of radiation that were used, which were more toxic. And there was also concern being raised about the potential neurotoxicity of this treatment as well. This culminated, though, in the publication of the OPERATE meta-analysis in 1999, which looked at 7 randomized controlled trials with about 1,000 patients, all of whom had a complete response after induction therapy. And we saw that at 3 years, there was about a 5 to 6% absolute benefit in overall survival, which was attributed to about a 25% reduction in the development of brain mets at 3 years. Unfortunately, there were a lot of limitations to the studies included in the meta-analysis. Most of them regarded imaging staging, so patients did not receive PET CTs at this time for staging. And there may have been a lot more patients with extensive disease than were detected. When patients completed their induction therapy, their restaging and treatment response was done with just a chest X-ray on most studies, and so complete response rates were probably overestimated. But the most important limitation was the lack of MRI. And we know that up to 15% of patients with small cell will have asymptomatic brain mets at diagnosis. So in reality, some of these patients on these studies were probably not receiving prophylactic cranial irradiation, but therapeutic cranial irradiation for unknown brain metastases, thereby inflating the survival benefit of PCI. A meta-analysis was done more recently. This study was published in 2023 in JCO, and they looked at over 200 studies with over 50,000 patients. And if you look at all those studies together, there was an associated survival benefit with PCI. But when you pared it down to studies that used MRI before to stage patients prior to PCI, there was no longer a survival benefit. And then furthermore, when they limited it to patients with to studies with randomized trial design alone, there was also no longer a survival benefit, suggesting the importance of patient selection. The best study that's been published in this space is referred to as the Japanese trial, or the Takahashi trial. And this was the first randomized controlled trial of PCI versus no PCI that required MRI staging. It included about 160 patients with extensive stage disease who had a negative brain MRI. And the trial was actually stopped early for futility because the patients who received no PCI in the experimental arm actually were approaching better survival than those who did receive PCI. And that was about 10 months in the group that received PCI versus 15 months in the group that did not. In the non-PCI arm, there was an MRI surveillance protocol that included MRIs of the brain every 3 months for the first year and then every 6 months after that. And unfortunately, about 80% of these patients on the study did develop brain metastases. But those who didn't have any worsening of their overall survival, which suggested that they were salvageable with radiation. And on the other side, there are 20% of patients who were able to be spared from radiation. Unfortunately, we don't really have the same kind of randomized data in the limited stage setting yet, but we do have retrospective data that is suggestive of a similar outcome. So on this study, there are about 300 patients who were propensity score matched, and about 2/3 of them received PCI and about 1/3 did not. And all of them underwent MRI staging. And again, we saw no difference in overall survival. The reason that we care so much about whether or not to give PCI is about the potential for neurocognitive toxicity. You can see on this pooled analysis of 2 RTOG studies that about 600 patients were included on. About 2/3 of them received PCI and 1/3 did not. And you can see in various cognitive domains, as well as in patient-reported cognitive function, there was worse outcomes in terms of neurocognitive toxicity in the patients who received PCI at 6 months, and that persisted at 12 months. There's a number of different things that contribute to the risk of neurocognitive toxicity after PCI. Age is one of the most significant ones, with the cutoff of 60 being significant. Doses of radiation is also significantly associated with neurocognitive failure, but this has been sort of clarified on other randomized studies, and a low dose is used as the standard approach now. Patients with the worst baseline cognitive function are more likely to develop cognitive failure after PCI. And then you also have to weigh the alternative of developing brain metastases, which typically can have a worse cognitive impact than the radiation itself. This graph also shows a number of adverse events related to different cognitive domains, with the top bars showing patients who received PCI, and on the bottom, patients who did not receive PCI, with significant increase in cognitive-related adverse events going out to 3 years, which is worse with the patients who received PCI. And this has really affected patterns of care. Despite PCI being a Category 1 recommendation for limited stage patients in NCCN, about 40% of patients do not receive it, mainly due to toxicity concerns. And there was also a 2019 survey of about 500 radiation oncologists that showed that after that Japanese study was published, PCI dropped significantly and very quickly in patients who have extensive stage small cell lung cancer. There are ways that we've been studying toxicity mitigation for patients receiving whole brain radiation and PCI. The 2 main developments have been memantine use and hippocampal avoidance. Memantine you've probably heard about as a drug in the Alzheimer's space, and it's been shown in various randomized studies now when added to patients' whole brain radiation to reduce the risk of neurocognitive failure, which is a small but significant improvement. And then added on top of that is hippocampal avoidant whole brain radiation. And you can see in this figure on the top 2 images are showing a hippocampal avoidant whole brain radiation plan. And these bottom 2 images are showing a standard conventional whole brain radiation plan, where the whole brain is sort of treated through and through. Whereas on the top, we're using a fancier technique of radiation called intensity modulated radiation, or IMRT, which can carve out an area in the shape of the hippocampi to avoid dose to that area. And that's also been shown with memantine to reduce neurocognitive failure. That being said, rates of neurocognitive failure are still relatively high. And so this has led to sort of developing the case for MRI brain surveillance rather than upfront PCI. The rationale is, again, based on those older studies that were done that showed a survival benefit. Those were done in the pre-MRI era. Now that we have MRIs, we can detect brain metastases early and salvage them early if needed. Ideally, this approach will avoid neurotoxicity in at least a subset of patients, and it's been shown in some studies to be cost-effective. So salvage radiation has been studied retrospectively in a number of studies. And the first study by Yao and colleagues, this was a real-world multi-center study of about 120 patients with limited stage disease. About half of them received PCI and half received MRI surveillance. And those who developed brain metastases in the MRI surveillance arm were salvaged with whole brain radiation, and there was no difference in overall survival. In the second study by Lee and colleagues, this was a multi-center study of about 1,300 patients with limited stage disease. Similarly, about half received PCI and about half didn't. And while PCI reduced the rate of brain mets, it did not have a survival benefit. And that makes sense intuitively. PCI is able to treat subclinical micrometastatic disease and prevent the development of brain mets in the future. But we have to ask, what's the clinical utility of that if we're still able to salvage patients who develop brain mets down the road? It was also shown on this study that patients who received SRS as their salvage radiation had a better survival than those who received whole brain radiation. So SRS stands for stereotactic radiosurgery. This is a form of targeted focused radiation which can be delivered with millimeter accuracy and allows the delivery of high dose of radiation to small areas with low dose to surrounding normal brain tissue. The goal of SRS is to escalate the dose of radiation to the target and thereby improving local control, and to reduce the dose of radiation to normal brain tissue, thereby reducing the risk of cognitive decline. In this figure of a patient with 7 brain metastases treated with linear accelerator-based SRS, the red is the prescription dose, and the blue is 50% of that dose, which you can see is very well confined to the area being treated. And in this patient's plan, the mean dose of radiation to the whole brain was only 1.7 gray, gray being a unit of radiation, whereas a typical whole brain plan is treated to 30 gray, and the mean brain dose is about 30 gray in those cases. This is showing what we call the beam's eye view in a linear accelerator-based SRS plan. So you can imagine yourself sort of sitting from the head of the machine where the beam of radiation is coming out. And what you're seeing moving are these little tiny lead leaflets called MLCs, or multi-leaf collimators, and they're creating really tiny apertures through which the beam is allowed to pass. And as that's happening, the arc is rotating around the patient from various angles. And by creating all of these various angles and apertures, we're able to create buildup of radiation in very small focused areas and low dose spread of radiation to the normal brain tissue around. The way that I describe it to patients is thinking about it like a spotlight on a stage. If you have 3 or 5 different spotlights converging on one place on the stage, it creates a very bright spot where the speaker is standing, but a lighter, less bright area and where there's just one beam or one spotlight coming from. And if you can imagine doing that to nearly an infinite number of times, that's how SRS kind of converges the dose of radiation. This is kind of the best data that we have for SRS salvage for patients who develop brain mets with small cell lung cancer. This is the FIRE SELC study, which stands for first-line radiosurgery, as compared to standard whole brain radiation. And they included about 1,000 patients from various institutions. About 13% of these patients had a high burden of brain mets, with more than 10 brain metastases at the time of development. And you can see in the graphs on the right, so this is showing the entire cohort receiving SRS versus whole brain radiation, that survival was significantly better in those who received SRS. And then they did a propensity score matched analysis, and the survival benefit of SRS remained over whole brain radiation, with SRS leading to a survival of 6 months versus whole brain with 5 months. On the right side, you can see a figure similar to one that I showed earlier in the talk, where there's an incidence of brain metastases over time. And you can see that patients who received SRS are more likely to develop additional brain metastases in the future. And again, that makes sense. You're not treating the whole brain, you're not treating micrometastatic disease, so it's more likely that they develop future lesions in the brain in the future. But as long as, the implication is that as long as you're doing regular MRI surveillance, you can catch those early and treat them with salvage. Other concerns with SRS are development of neurologic mortality and leptomeningeal progression, but they saw that the rates of those were quite low on this study. So we have a randomized study open now to try to answer this question more definitively, where patients who develop brain mets with small cell lung cancer are randomly assigned to receive salvage radiation with either SRS or hippocampal whole brain radiation. So that'll help guide things in the future. Another area that's sort of uncertain right now is how PCI factors into immunotherapy. All the studies that have been done to date were not in the immunotherapy era, so it's hard to know how PCI interacts. The best data we have in this space so far is from the Adriatic trial, in which patients with limited stage disease received adjuvant immunotherapy after upfront systemic and radiation therapy. And it showed that there was actually an overall survival benefit associated with PCI, and it was actually pretty significant, from 50% to 62% at 3 years. But it's hard to hang our hat on this data since PCI was done at physician discretion, and we're not really sure how MRIs were used on the study. So that kind of segues to the last topic, which is the Maverick trial. This is an open SWOG study, which is hopefully going to provide definitive evidence on the role of PCI in small cell lung cancer going forward. These patients all receive PET staging, they all receive MRI at baseline, as well as an MRI surveillance protocol similar to the one used in the Japanese trial, where they receive MRIs every 3 months for the first year and every 6 months for the second year. It's an inclusive study of both limited stage and extensive stage patients, so it should be able to guide data for both of those and treatment recommendations for both of those populations. And they're looking at overall survival as their primary outcome. So this should answer the question, is PCI, is MRI surveillance non-inferior to PCI in these patients? And they're also looking at cognitive and quality of life outcomes. Until we have this data, I think it really comes down to patient selection in terms of whether or not to offer PCI. Thinking about those baseline factors that may increase their risk of developing neurocognitive toxicity, such as performance status, age, and baseline cognition. In terms of stage, we already have data that's randomized from the Japanese trial that extensive stage patients don't have a survival benefit to PCI if using MRI surveillance. And there's also data that patients with limited stage disease who have an excellent response to first-line therapy also may not have a benefit to PCI. And it also really comes down to the values of the patient and shared decision-making, weighing the risks of cognitive function versus their desire to have more complete disease control. And then also thinking about whether patients will be able to adhere to a close MRI surveillance protocol. So all that together, just to say we don't really know the answer yet, but it just comes down to each individual patient. That's all I got. Any questions? Yep.
What site is the NRP60
open? I don't know. It's not open as far as I know in Louisiana.
I've worked at clinical trials, I'm currently trying to open it. but not just for this question.
Good question, yeah.
For a whole brain radiation, at what point would you consider that for patients, not prophylactically, but as treatment instead of the CNS?
It's really difficult. So I think Dr. Keane alluded to the fact that we're kind of pushing the envelope on number of brain metastases to treat with SRS. And I don't really have any kind of strict upper limit. I think if it's like probably like 30 is the most that I've ever seen treated, maybe up to 35. But it depends on sort of like their disease progress, like how controlled is their extracranial disease, what's their performance status, what's the distribution of the brain metastases, are you able to spare normal brain tissue in between? So it's very individualized, but I don't really have any strict cutoff.
Thank you.
Thanks so much.